Good afternoon, everybody. I'm Dr. Tiffany Cook, and I'm delighted to be presenting to you all today. I'm a community psychiatrist, so while I've worked in private settings, the majority of my work has been focused on traditionally underserved populations and in public health. I've worked in a variety of settings, multiple community health centers in Georgia, Georgia State University, and Morehouse School of Medicine, along with Grady Health System, and DeKalb County Accountability Courts, and private practice. In addition to traditional psychiatric clinics, I've worked in primary care and HIV clinics as well, using an integrated approach to treatment. My work has given me clinical and program development opportunities, both here and in Haiti, and I'm currently providing inpatient, consult liaison, and ER clinical care in Georgia. Again, I'm excited to be with you all today. So let's get started on survivors, stress, and substance use, examining the connection between trauma and substance use disorders. So the purpose of today's webinar is to examine the bidirectional relationship between trauma and substance use disorders. Environmental, biological, and psychological factors that predispose survivors to co-occurring PTSD and substance use disorders will be highlighted. The webinar will also discuss the various treatment options for trauma-related disorders and substance use disorders. So our objectives for today: at the conclusion of this activity, participants will be able to list the diagnostic criteria for post-traumatic stress disorder, name at least 2 psychological factors leading to the co-occurrence of PTSD and substance use disorders, name at least 2 physiological factors leading to the co-occurrence of PTSD and substance use disorders, identify at least 2 treatment modalities for persons with co-occurring trauma-related disorder and substance use disorders. So let's talk about trauma and substance use disorders. They have an intertwined relationship. One doesn't always cause the other, but in many cases, one can lead to the other or worsen the impact of the other. So in this sense, the relationship can be bidirectional and cyclical. The substance use disorder can come first, leading to trauma with the actual use of the substance being the trauma, or the situations in which the person used, or the settings they were in, or the environment being the trauma, or traumatic experiences that can occur because a process is trying to use the drug or obtain the drug. In some cases, the trauma may come first, with people self-medicating with drugs in an effort to diminish the emotional distress of the trauma. And this is really important because with 70% of US adults having experienced at least one traumatic event in their life, these are important facts to consider. So let's talk about diagnoses and risk factors for PTSD and substance use disorders. So trauma is an event that leaves a person in an extreme state of fear of imminent death or destruction or physical or mental harm. Not everybody who suffers a traumatic experience will develop PTSD, but about 20% of people can. For the purposes of this presentation, I will be speaking of trauma as it relates to people who have PTSD. Even though I'll be primarily focused on PTSD, even people with a history of trauma and that don't have PTSD are still at an increased risk for risky substance use. So let's define PTSD. According to the DSM-5, the first diagnostic criteria is exposure to or learning of actual or threatened death, serious injury, or sexual violence. The next criteria is having intrusion symptoms after the trauma occurs. So that's like your distressing memories or nightmares or flashbacks to the trauma, or emotional distress when being reminded of the event. The next criteria for diagnosing post-traumatic stress disorder is a person will typically avoid any stimuli that's associated with the event. With PTSD, people often have negative alterations in cognitions and mood. So that means they'll forget certain aspects of the trauma or feel detached or emotionally estranged. And PTSD is also associated with marked alterations in arousal and reactivity. So this is where you get the clinical symptoms of hypervigilance and being startled easily, insomnia, reckless behavior, and poor concentration. And PTSD symptoms last longer than 1 month. A diagnostic criteria for PTSD is that it must cause clinically significant impairment in functioning. So this isn't just feeling bad after trauma or feeling a little bit down after you've gone through something traumatic. This is where your functioning is impaired in your social life or your work life or your relationships. And PTSD is not due to substance or other condition. So there are some risk factors that predispose a person who has undergone trauma to developing PTSD. Women are more likely to develop PTSD, and being younger at the time when the trauma occurred, the more likely to predispose someone to develop subsequent PTSD. Women are about twice as likely as men to develop PTSD. There are also some environmental risk factors for PTSD. So prior to any trauma occurring, a person with low socioeconomic status, decreased or lower education, a history of childhood adversity, being a member of a minority racial or ethnic group, and a family psych history, those things predispose somebody to develop PTSD if they should have a traumatic event happen. Around the time of the trauma, if the trauma is severe, if the person perceived the threat ahead of time, or if they were a perpetrator of something. So typically in the military, if somebody had to fire at someone during combat, or a person experiences dissociation or flashbacks, or can't remember, or feels like they almost had quote unquote an out-of-body experience as part of the trauma, that's a risk factor for later developing post-traumatic stress disorder. After the trauma, if a person has repeated reminders of it or experiences other adverse life events or some kind of loss related to the trauma, they're at a higher risk of developing PTSD. Having good social support is protective both ahead of time, before the trauma occurs, and after. There's some temperamental risk factors for development of PTSD as well. So prior to any trauma, a history of childhood emotional problems before the age of 6 or prior mental health disorders later predispose somebody to develop PTSD should they encounter trauma. After trauma, if somebody is negatively criticized or if they have inappropriate coping skills or they develop acute stress disorder, they're more likely to develop PTSD. An acute stress disorder is those PTSD symptoms that we named as diagnostic criteria, but those symptoms occur within 1 month of the trauma. Remember, for it to be diagnosed as PTSD, symptoms have to last at least 1 month or longer. Acute stress disorder is when you get those symptoms that happen less than 1 month after the trauma. So about 8 million people in the US have PTSD during a given year. So let's talk about substance use disorders and how they're diagnosed. Here I'm using the general term of substance use disorders to encompass alcohol use disorder, cannabis use disorder, cocaine, opiate, sedative use disorder, stimulant use disorder. While each specific substance use disorder has specific characteristics, in the interest of time in the presentation, I'm going to give the general diagnostic criteria for substance use disorders as a whole. So to diagnose a substance use disorder, there has to be impairment or distress in at least 2 of the following domains that I'm going to go over in a 12-month period. So impaired control, where a person uses more of the substance than they intended or for a longer period than they intended, and makes attempts at cutting down or cutting back that are unsuccessful. This is where you'll find a person spending huge amounts of time trying to use a drug, get the drug, or recover from the effects of a drug. And a person will also have cravings. You'll also note impairments in social domains, such as failure to fulfill work obligations or family or social obligations. A person will use despite interpersonal problems and social problems that are caused by substance use. Social work and recreational activities will be given up because of use. Another criteria is risky use. So when a person continues to use, even when it's become physically hazardous for them to do so, or when a person continues to use despite knowing that they have a problem. Pharmacologically, tolerance or withdrawal develop in substance use disorders. So just like there are risk factors for post-traumatic stress disorder, there are genetic and physiological risk factors for substance use disorders, like a family history or the presence of other psychiatric disorders. There are also environmental risk factors for substance use disorders. And again, some of these are more specific to particular substance use disorders, but in the interest of time and being general in the presentation, put a lot of the common risk factors here on this slide. So cultural attitudes towards use influences risk for substance use disorders. If it's popular to use, availability of the substance, what's the person's personal experience with the substance. Stress levels play a role, as well as peer use and the exaggerated personal expectation of effects. So what does the person think that they're going to achieve by using it? Suboptimal coping with stress, academic failures, tobacco smoking, and low socioeconomic status. So again, these are some risk factors for developing a substance use disorder. There's some temperamental risk factors as well. So a history of conduct disorders or antisocial disorder, a history of bipolar disorder, particularly being impulsive with bipolar disorder, a lot of novelty-seeking behavior, a history of schizophrenia. And if you have one substance use disorder, you're more likely to have a second or third. About 20 million US adults have substance use disorders in a given year. Although PTSD is more common in females, comorbid PTSD and substance use disorders tend to be seen more in males. So I think it's important to talk about the science behind both substance use disorders and PTSD, because too often persons with these disorders view them as representative of character flaws or think of them as representing a weakness. With my patients in practice, when I point out that there's biology and physiology behind these conditions, just as with diabetes, hypertension, hyperthyroidism, it goes a long way toward destigmatizing the condition. Also, many people already know that there's a science behind the disorders, but a key question I often get is, what exactly is the science behind it? So let's look at dopamine, which is responsible for pleasure, reward, and reinforcement. So neurotransmitters, they're just hormones in the brain area. When we do something pleasurable, like our hobbies or eat our favorite food or anything we enjoy, we get an increase in the neurotransmitter dopamine in the area of the nucleus accumbens, this area right here, just below the cerebral cortex. This enhances a reward circuit in our brain, which makes us want to repeat that pleasurable activity. And we do this even subconsciously without realizing it and realizing that drive to repeat that activity. So let's look further at the diagram to kind of distinguish the normal reward pathway from the substance use reward pathway, which is like comparing a whisper to a loud radio. Let's say we eat our favorite food. That normal reward pathway is triggered. So you see a small increase in dopamine represented by these gold circles when you do something like eat your favorite food or engage in your favorite hobby. But now look on the right. When you use a drug, and in this example, we use cocaine, you see a huge surge of dopamine. And you have a flooding of that nucleus accumbens with dopamine, up to 10 times more than a normal reward and in a shorter time frame. So just like we turn down the volume on a loud radio, the brain of a substance user adjusts to this surge by producing less dopamine or making your receptors less sensitive to it. So this is why a person who misuses drugs eventually feels depressed and can't enjoy things that they normally used to. Now the person needs to keep taking drugs to experience even a normal level of reward, which worsens the problem and now leads to a tolerance. Let's take a look at the role of the amygdala. This is science behind PTSD. So when your body senses a threat or a trigger for trauma, an area of the brain called the amygdala, that's this area right here, is triggered. And the amygdala plays a role in modulating stressful feelings and activates your fight or flight response. So this gets triggered when you sense a threat or something that reminds you of trauma. This area also allows for creation of new trauma-related memories. The amygdala in someone with PTSD is more reactive than the amygdala in someone without PTSD. The same amygdala plays a role in substance use disorders. Drug use makes the amygdala more sensitive and thus a little bit more reactive. So imagine a person with comorbid PTSD and substance use disorders. The amygdala is triggered by trauma and it's more sensitive to even the slightest trigger due to the drug use. So that triggered amygdala activates fight or flight. And clinically, you see irritability, anxiety, unease, and a person becomes more likely to then use drugs to try to quell those feelings or stop that irritability and anxiety they have. And as the person increases his or her use, the amygdala becomes even more sensitive, causing even more irritability, discomfort, etc., and the urge to use again. So we see how this cycle just keeps continuing. In the picture, they use a response triggered by vision, but this same response can be triggered by smell or hearing or anything that reminds someone of trauma. So both PTSD and substance use disorders can activate fight or flight, which causes the release of adrenaline, also known as epinephrine, or noradrenaline, aka norepinephrine, and can also cause the release of cortisol. So activating the fight or flight system in and of itself isn't always bad. It helps us to avoid danger or flee from danger. And a little adrenaline can be helpful. But chronic activation of fight or flight can lead to physical conditions such as osteoporosis, labored breathing, muscle tension, increased heart rate, hypertension. Your digestion can be inhibited, pupils dilate, you sweat, you get tremor. You have an altered immune response to fighting off disease and other conditions. Again, people may wish to self-medicate these physical symptoms with drug use, and as a result, the cycle just keeps continuing. Many of the drugs that people use contain adrenaline or norepinephrine, and thus this adds to the adrenaline that's already present from fight or flight, and it worsens the physical effect that the person was seeking to numb using the drugs. And again, the cycle continues. Let's talk a little bit about the prefrontal cortex. So this is an area of the brain responsible for attention and awareness and decisions. It regulates conscious behavior and assigns emotional significance to events. It modulates emotions, corrects dysfunctional reactions. So just like the amygdala triggers fight or flight, the prefrontal cortex serves in essence to calm down the fight or flight response. But in a person with PTSD, the prefrontal cortex is less activated, meaning that fight or flight response just continues and it just remains prolonged and it doesn't shut off. The prefrontal cortex also serves to modulate impulse control, but there's a shift in balance between the reward circuit with dopamine that we talked about and this prefrontal cortex in substance use disorders. So that means it gets harder to regulate cravings. So again, in a person with both a substance use disorder and PTSD, it's even harder for the prefrontal cortex to modulate emotions. Let's talk about the neurotransmitter GABA. So GABA increases the level of growth hormone. In ADHD, it can improve focus. It can decrease inflammation, provide relief of PMS symptoms, decrease depressive symptoms, decrease anxiety symptoms, and improve sleep. So it kind of reduces the stress-induced actions of the amygdala. But GABA levels are lower in times of stress and tend to be lower in people with PTSD. And as a result, clinically, you see they have more depression, anxiety, insomnia. So in seeking to reduce these symptoms, they may take substances like benzodiazepines, so Xanax, Valium, Klonopin, which increase the action of GABA. But when those substances are taken incorrectly or for too long a period, these GABA-like effects can lead to a tolerance. So let's kind of summarize. An increase in adrenaline leads to fight or flight. So clinically, what this means is that you end up seeing a person who presents with hyperarousal or hypervigilance or disrupted sleep. In PTSD, there's less GABA, so less of that natural tranquility. So the way this manifests clinically is depression, anxiety, insomnia. In a person with PTSD, a hyperactive amygdala and a hyporeactive prefrontal cortex clinically leads to a picture where you've got prolonged activation of fight or flight, which leads to reactive anger, impulsivity, motor activity or fidgeting, and increase in negative emotions. So substance use disorders. Chronic use can make brain regulation of GABA, of dopamine, and adrenaline difficult. Withdrawal, anxiety, depression, irritability, and dependence result clinically because of that dysregulation. That dysregulation and that feeling of depression and anxiety can trigger trauma again and be a reminder of the trauma, and again, make a person more likely to use, and that cycle just keeps continuing. Because PTSD heightens the symptoms a person experiences when they withdraw for a drug, a person with PTSD may be even more triggered to use to stop experiencing the substance use withdrawals. So again, we see all these ways in which there's a cyclical relationship. So to talk about that relationship again, going back to that early slide in the beginning that represented that cycle and that bidirectional relationship. Substances provide a temporary respite, but a person ends up with worse PTSD symptoms when withdrawing. It makes it harder to stop using. Substance use alters decision-making, and then that puts a person at an increased risk of subsequent trauma. The substance use delays treatment progress in the remission of PTSD symptoms. And this is not to mention that PTSD and substance use disorders may co-occur with other psychiatric disorders, even further complicating the experiences of these symptoms. And this is why treatment is so imperative. So just to illustrate that cycle, and again, people come in, some people have the trauma first, and some people have the drug use first. But let's kind of go through this cycle. So again, somebody may experience trauma and feel subsequent distress or shame and begin to self-medicate with drugs, or just out of curiosity or for stress relief, use a substance or drug. As a result of that use, they may lose their job or relationships or have health consequences. Because of those consequences, that distress increases even more, leading to even more shame, more trauma, and now you've got a decrease in your coping skills. Because you feel even more distressed than you did to begin with, to overcome that, somebody may be more tempted to use drugs as a temporary escape, and that leads to tolerance. Again, the consequences worsen and it becomes harder to resolve. So let's talk a little bit about treatment options. So statistics vary pretty widely, but 50% or more of people who seek treatment for substance use disorders meet criteria for current PTSD. And people with PTSD and substance use disorders tend to have worse treatment outcomes than those that don't have that comorbidity. People with PTSD are about 2 to 4 times more likely than people without PTSD to have a substance use disorders. And the prognosis for people in substance use treatment who have co-occurring PTSD is worse than compared to those without PTSD. So just to give an example, individuals with co-occurring PTSD report more intense cravings for alcohol and drugs, and tend to relapse more quickly than individuals without PTSD after treatment is completed. The comorbidity is associated with a more complex and costly clinical course than with PTSD or substance use disorder alone. And also, you have more chronic health problems and worse social functioning, higher rates of suicide attempts, more legal problems, and increased risk of violence. Treatment adherence is worse, and there's less improvement in treatment. So this speaks to the need to provide trauma-informed care. While there isn't a gold standard, best practice is an integrated approach to treatment, especially in the context of the advancements that have been made over the last decade. The concurrent treatment of both disorders offers a much better prognosis, but too often people receive substance use disorder treatment only first, and then are referred to PTSD treatment or vice versa. So an evidence-based module is seeking safety, and this is one of the most popular, most widely used because it's a very flexible, very good model. You can use any number of sessions, but often they're about 25, 60 to 90-minute sessions to correspond with the 25 topics in the Seeking Safety modules. The focus of Seeking Safety, just a few of the topics are decreasing risky behaviors, and setting boundaries, and coping with triggers. And again, this is a very popular module due to its flexibility, its ability to be used in adolescents or adults. It can be used in individual settings or group settings. A lot of times you see it frequently used in vulnerable populations, so people who are homeless in the criminal justice system, people who've experienced domestic violence, military. It can be done in an inpatient setting, an outpatient setting, rehab. So again, it's a widely used, widely popular model. Next is prolonged exposure. And most people want to avoid anything that reminds them of the trauma they've experienced, but by doing so, that reinforces their fear. When you face what's avoided, a person can decrease symptoms of PTSD by actively learning that the trauma-related memories and the cues aren't dangerous and don't need to be avoided. And so prolonged exposure is a treatment that's highly recommended for PTSD. In previous years, it was selected by SAMHSA and the Center for Substance Abuse Prevention as a model program for national dissemination. So prolonged exposure typically consists of 8 to 15 weekly sessions. There's gradual confrontation of the fearful stimulus, and psychoeducation is provided. There's breathing training and relaxation techniques. So there's imaginal exposure, in which the trauma is described and those descriptions are recorded. The emotions are processed, that recording is replayed, and those emotions are activated, but this time in a safe context. And there's in vivo or real life exposure. So this is when somebody repeatedly engages in the situations that are traumatic or that they avoid because of the trauma. And by doing so, this proves to the person that it's not dangerous. So they're engaging in these avoided situations, but they're showing that it's safe to do so. And with the concurrent treatment of PTSD and substance use disorders, the COPE model is an adaptation of this, and their relapse prevention is incorporated into therapy. Another treatment is EMDR, or eye movement desensitization and reprocessing. So this treatment typically occurs in 8 phases. There's history and treatment planning. There's preparation that establishes trust between the person and the provider. There's assessment to establish negative feelings and identify positive replacements. There's desensitization, which includes the eye movement technique that we're going to discuss. Installation, and that strengthens positive replacements. A body scan to see if the client is now able to bring up memories of the trauma without experiencing negative feelings. Closure, and that happens at the end of every session, and reevaluation, which happens at the beginning of every session. So with the desensitization, the trauma is recalled, and the person tracks the therapist's finger movements with his or her eye. There's a reformulation of negative beliefs, and that decreases hyperarousal. With this, you have to seek a provider that's specifically certified in the training. Transcend is another treatment model, and this is used in veterans. So once someone has had substance use disorder treatment at a VA facility, there is a 12-week program, which consists of 6 weeks of skill development and 6-week group trauma processing. It's a partial hospitalization program that incorporates elements of psychodynamic therapy, CBT, and 12-step programs. And there are other therapeutic treatments, such as rehab. And rehab can be long-term and something that's done in an inpatient facility or residential facilities, or it can be done on an outpatient basis, and they can be anywhere from 30 days to several months. 12-step programs are also very good. AA, NA, CA, Celebrate Recovery. CBT, traditional CBT, which is aimed at restructuring negative thoughts and core beliefs, is also a good traditional model. But integrated CBT, which is an 8 to 12 session protocol that includes modules such as breathing retraining and PTSD psychoeducation and CBT coping skills like relapse prevention and cognitive restructuring is also appropriate, as well as peer support. Whatever method people choose, just remember that it should be culturally appropriate, and make sure that the survivor is an active participant in his or her recovery and in selecting the treatment modality. And remember, it oftentimes takes a combination of several methods. Also important are lifestyle modifications. So spirituality, meditation, exercise, diet, hobbies. The use of apps now too help with lifestyle modifications, so people can find out what lifestyle modifications may be appropriate, track their progress. Those apps can aid them in what to do and provide instruction in those lifestyle modifications. It's just important to keep busy because many people have to discover what they like to do or rediscover what they like to do. What did they enjoy pre-trauma? What did they enjoy prior to substance use? And many people have been dealing with these conditions for so long that it can be difficult to recall what brings pleasure. A good key with lifestyle modifications is to also have an accountability partner, because unlike therapy or medication visits, you're not necessarily required to check in with another person when you're doing a lifestyle modification. So having somebody get an accountability partner to help make sure that they're incorporating that into treatment is key. And there are some pharmacological ways to treat PTSD and substance use disorders. So there's detox, and this is where a person is treated in a hospital setting with medication to prevent withdrawals from alcohol or opiates or benzodiazepines. A lot of times people use detox as a standalone, but I caution that detox should always be followed by rehab or with some kind of therapy, because once you get the substance out of your system or once you prevented the withdrawals, that's just one step in recovery. So how do you manage the cravings? You know, how do you do those things that we just talked about, rediscovering what you enjoy? So a lot of times people will go for detox, but there needs to be a step after that, or several steps. There's also medication-assisted treatment, or MAT. The goal of MAT is to normalize brain chemistry and to kind of stop the euphoric effects of alcohol and opiates and manage those physiological cravings and kind of normalize the body functions without the negative effects of the abused drug. So the medications in MAT are, again, provided as a plan that includes therapy and social support and shouldn't be used as just a standalone. So a psychiatrist can evaluate someone to determine which medication will work best for them and make sure there is no physical contraindication. And again, kind of make a determination based on that person's unique profile. So to manage opioid use disorders, methadone is available. And this is the only MAT drug that can be used in pregnant or breastfeeding women. And the way it works is it tricks the brain into thinking it's getting the drug, but the person is not getting high, so withdrawal symptoms are prevented. And this has to be administered and supervised in a structured clinic. There's buprenorphine, which reduces cravings and provides a euphoria effect, but there's a ceiling or plateau to that effect. And it can be sometimes paired with naloxone to prevent withdrawal and decrease the likelihood of misuse. There should be at least 12 to 24 hours where the person is opioid free before initiating treatment with this medication. Naltrexone can be given via a shot once a month, or it can be given via pills or tablets. If somebody who's taking naltrexone relapses, the effects of that euphoria and the sedative effect of the substance is blocked. It's best to avoid this medication in someone who has liver damage, and that the person be opioid free 7 to 10 days before initiating. For managing alcohol use disorders, disulfiram is a very old medication, but a very effective one. The person should be at least 12 hours away from their last drink, because the way disulfiram works is that it blocks alcohol metabolism. And by doing so, it causes nausea, facial flushing, vomiting, headache, and this can occur within as little as 10 minutes of drinking. So a person is less likely to drink if they're taking this medication, because they know they're going to feel those effects. Acamprosate can decrease alcohol cravings. A person should be alcohol-free for at least 5 days before initiating it. And the onset of action for that is about 5 to 8 days within taking. And naltrexone, which I already discussed, is also useful in alcohol use disorders, not just opioids. There's also other pharmacologic treatments. So antidepressants, anxiety and depression are common in both post-traumatic stress disorder and substance use disorders. So these classes of medications are extremely important. Antidepressants can help reduce trauma, depression, and they also help reduce anxiety symptoms. The gold standard in post-traumatic stress disorder and generally in depression is SSRIs. Those are medications like sertraline, paroxetine, fluoxetine, Celexa, and you can use other medications or other antidepressants, SNRIs, or whatever may be clinically appropriate for that person. But SSRIs are some of the most popular. And I put an asterisk by sertraline because that has approval and wide use in persons with PTSD. Anxiolytics are medications to treat anxiety. So in a person with comorbid post-traumatic stress disorder and substance use disorder, you want to stay away from benzodiazepines as much as possible, just so that you don't potentiate another addiction or cause familiar cravings to that person or a tolerance. So you want to try to use non-benzodiazepine medications. Hydroxyzine and buspirone are very good and very popular for that purpose. Antipsychotic medications are useful in nightmares and flashbacks and impulsivity symptoms that can occur, the impulsivity in PTSD, but also in substance use disorders. So these are medications like risperidone, quetiapine, aripiprazole, ziprasidone, olanzapine. Prazosin, this is a blood pressure medication, but it's effective and has some use in PTSD nightmares and targeting those nightmares and reducing those symptoms. And topiramate, which is a seizure and headache medication, can also be used off-label for nightmares and re-experiencing. So again, I want to advocate for people to use a combination of therapy and medication, and recruit members of the person support network to engage them and encourage treatment, and seek resources and let the person know that they are not alone, and that PTSD and substance use disorders, along with the co-occurrence of both, are very common, and remind them that there's no need to be embarrassed, and that, as we saw today, there's biology behind why these disorders develop. And just make sure no more than a person with diabetes should feel ashamed should the person with these disorders. Okay, these are my references. And at this time, I want to thank you all for participation. My contact information will be provided, but before we get to that, I want to give it back to Ms. Trent to open it up for questions.
So Galaxy asked, how does this relate to with complex trauma?
When you say how does it relate, can you give me a little bit more information about what you're asking? So with complex trauma, kind of like in general, while you're typing that out, when you go back to those circuits or pathways, people with trauma often experience hypervigilance, hyperarousal, and there's biology behind that. One, the psychological distress, but again, as we talked about with the decrease in GABA, that lowered ability of the prefrontal cortex to shut off that fight or flight mechanism. The more complex the trauma, the more likely that a person is to develop PTSD, the more likely they are to have triggers. So once they have those triggers, and that the more likely they are to have that fight or flight response continuously turned on, and that's how they get those symptoms of the hyperarousal, hypervigilance. And when you combine that with the substance use disorder, again, people often want to use to eliminate some of the unpleasant physical symptoms that come from PTSD, as well as the psychological symptoms. So I hope that answered your question, but if you want something a little more specific than that, let me know.
Okay. Another question that came in is there any research or statistics regarding PTSD and domestic violence?
Yes, there is. I don't know like what specifics you want, like as far as prevalence or PTSD and domestic violence as related to other types of trauma, but the incidence of developing PTSD is higher, again, in women, and not that women are the only victims of domestic violence, but I think women experience domestic violence at higher rates. So yes, people with domestic violence are at higher risk of developing PTSD. And then also when you go back to those slides that show adverse life experiences and challenges even prior to trauma. So, you know, those kind of things predispose somebody to later developing PTSD. So gender, how old are they when the domestic violence occurred? How many episodes of domestic violence did the person experience? Did they also grow up in a household where domestic violence was present? So the more you can say yes to those questions, the higher the risk becomes. Even people who are the perpetrators of domestic violence. Again, we talked about being the perpetrator being a risk factor as well. So yes, there's huge correlation.
And Megan asked a question about historical trauma for specific populations such as African Americans.
Yes, and remember too, one of the diagnostic criteria is not just personally experiencing trauma, but hearing about trauma and learning about trauma. But yes, as part of, remember also too, there was a slide where I talked about being a member of the rate of a racial and ethnic minority group. Again, historically, just the history that Blacks have had in this country as far as slavery, as far as Jim Crow, as far as voter disenfranchisement, criminal justice system, all those predispose. So one, again, if you directly experienced that, again, having seen it passed down generation to generation, if it's something your parents experienced, or maybe the person may feel further removed from it themselves, but their mother, grandmother, whomever experiences that, yes, there is a huge, huge, huge risk. And again, it doesn't have to be something that's personally experienced, but it can be listening to a story or reading about a story as well. So yes.
Okay, great. Terry wanted to know, are there proven techniques an individual can do on the spot to calm down the fight or flight response to active prefrontal cortex so that it regulates impulse control?
One of the best ones is deep breathing, because when you have that fight or flight kicked on, your breathing is going to accelerate, and that automatically is going to make your heart rate accelerate. Counting backwards from 10, one, it kind of makes you focus on something other than the trauma because you're counting and you're counting backwards. That's slowing things down in your mind, which slows that fight or flight. But some long, shallow, deep, slow breaths can really help calm that down, because that signals to your body that things are okay. There's also muscle relaxation techniques that can be done, but deep breathing is one of the best and most effective. It's quick, you can do it on the fly, and it really does work.
Okay, and Corey asked the question, as it pertains to this presentation, it seems like it was addressing the adult population. However, he's seeing a lot of adolescents and younger and youth using drugs. What do you recommend in how to deal with these two populations?
You're right. Most of this was catered towards an adult population because I am an adult psychiatrist, so I'm not an expert at child and adolescent. But again, seeking safety has been approved for use in adolescent populations, and I'm honestly not the best person to talk about, what medications. SSRIs can definitely be used, but as far as getting more specific than that, I defer to someone in child and adolescent psychiatry.
Okay, great. And we had someone who sent in an anonymous question. Some of the methods for treatment of PTSD seem like they can address a one-time traumatic event, but what methods are shown effective for treating repeated traumatic experiences?
All of these can be used for a one-time traumatic episode, and all of these can be used in people who've had an extensive history. So again, if we look at something like Seeking Safety, where there are 25 modules, and again, treatment can go beyond 25 sessions. So it really can be adjusted where treatment may last longer for somebody who has had more trauma. But again, the medications, they kind of treat the biology in those pathways. So whether somebody's been impacted by one trauma, two traumas, or just has a history of even more than that, the medications will help. And the therapy can be tweaked on an individual basis. So these are kind of just blanket overviews, but all of these therapeutic medications and therapeutic interventions and medications are effective whether somebody has just had one episode or whether somebody has had multiple episodes. It just may take a longer period of time for someone to see effect.
Okay, great. Well, as we stand now, we had a few comments to come in which expressed special thank yous for your presentation and saying that this was great. And also, for those who are wondering, there are no CEUs available for this presentation. However, we will make it available on our website to continue to use it as an educational opportunity. Yes.
No, thank you all so much. We had a lot of participants. Thank you all so much for such wonderful questions. I appreciate the feedback. If anybody wants to contact me directly or has further follow-up questions, please feel free. Here's my contact information. So feel free to call or email if you have further questions or want to chat about anything that I discussed a little bit further.
All right, great. Well, again, thank you, Dr. Cook, and thank you all for joining our webinar.